AYUSH doctors provide the primary care treatment in the whole pyramid of primary, secondary, and tertiary care. So, all of you will be handling the diseases primarily, and you will be promoting preventive aspects as well as basic treatment that's required at the first contact level. That's why the topics today are very much relevant. Dr. Yogesh will be speaking on preventive aspects of that, and I'll be focusing on another important lifestyle disease, or rather combination of lifestyle disease, that's hypertension and diabetes. The topic is challenges. It's a real challenge for both the patients and the caregivers. For patients, it is challenging because for them the results are not tangible immediately. In infectious disease, you provide treatment within say about 7-10 days to see the result. Whereas in lifestyle diseases, the results are not available immediately, so there is always a question of uncertainty for the patients. And second thing is, it's a lifelong treatment. So the compliance is a very big issue in these conditions. And added to that is the cost factor. So it's a major challenge for the patients, and for the physicians or doctors, the problem is that to maintain the relationship for a long period of time, and also to change your approach with the change in the data or with the new inventions and discoveries and guidelines. Even in the field of diabetes and hypertension, things are evolving rapidly. In fact, in diabetes, every year there will be new guideline. American Diabetic Association comes with a guideline every year. Similarly, hypertension also is another field where things are changing rapidly. Many medications which were very popular earlier, they are slowly going out of the usage. Probably because we have understood better and we are getting newer medications also. So we will be going through all these changes that are happening in the field of hypertension and diabetes. And we will start, next slide please. We will start with we'll discuss it along with one of our patients. So the patient is, the previous slide. Let us talk about a patient who is 45 years old, male, quite obese. He comes for a routine checkup. This is what we see routinely. People are very much in favor of doing tests, but not anything beyond that. They just want piles of reports and measurements. Every year they will come religiously like annual vehicle checkup. They want their checkup to be done, and it stops there. And so here is one of a similar patient, 45 years old. He has come for routine checkup. BP is 140/90. What next? So the number is already there. He is already in the threshold. He is already almost crossing the border, and what next? The number of 140/90 is a cutoff point, is correct. But is it such a number that we have to start it for all of them, or does it mean that anyone who is less than that is safer? Not necessarily. Blood pressure is a continuous number. We put arbitrary classifications just for sake of our convenience. First visit 140/90. So the first point is that we should not get alarmed, or we should not get frightened by one single number. What matters is, has that number produced any harm to the patients? Are there any damages to the organs? In which case we should act immediately. If not, there is scope for waiting for some time, maybe alteration of lifestyles, and then decide. So whether to start aggressive treatment or whether to go by lifestyle modification depends upon whether that number has produced any damage to the that patient and other organs. Next slide. So first thing is, are we recording what we were supposed to record, or could there be mistakes or errors in that? Measurement is a very important point in all these things. For fever, we should get a proper thermometer. If you are talking about patient with breathlessness, you need a good saturation probe. If you are talking about blood pressure, you must have a good BP apparatus and a proper technique of measurement. Because everything depends upon that particular measurement. So the measurement has to be done by proper equipment, validated equipment with the proper method. We need to calibrate our machines, BP apparatus periodically, especially the newer spring ones, anaeroid equipments. They need to be calibrated at least once a year. And then we should have proper technique of measuring the blood pressure. Now there is a slow trend towards out of office blood pressure measurement. What we measure in our clinic is one snapshot of at one point of time. Usually when they come to us, they are actually the out of office measurement is the representative of the true blood pressure. Suppose the BP can be recorded at home. That probably is the ideal blood pressure. So if your patient says the recording of the blood pressure at home is 130 by 80 and what we record in the clinic is say 150 by 90 or 94, we should go by what has been recorded at home with proper methods. That has been a major change which has been seen during the last 4 to 5 years. Similar to what the revolution was noted with the glucometers. You cannot manage a diabetic properly without a glucometer at home, self-monitoring of the blood glucose. Similarly, a good management of hypertension requires a good measurement at home also. Although it is the ideal way, it is not practical, but we should encourage our patients to have a good BP apparatus and measure it at home. Ideal, but may not be practical yet. But we should promote that culture. And white coat hypertension is one condition where the recordings are high in the office, in the clinic, but when they go home, when it's checked afterwards, the blood pressure recordings are normal. So the BP recording is office measurement with the proper equipment. Earlier we had mercury equipment, but now mercury is banned now, so most of us will have spring, that anaeroid blood pressure recorder. Or automatic BP recording instruments are also available. Both of them can be used, and at home we should encourage patients to record with automated blood pressure recording equipment. There is one more tool which is quite useful, that is 24-hour ambulatory BP recording. This is the ideal way of recording the blood pressure status and the response to treatment. Blood pressure is not a single fixed number. For that matter, every biological phenomenon has fluctuations and cycles. It is never a static number. Life is always dynamic, not static. Similarly, all biological parameters are dynamic, not static. What we record in our clinic is a static number which may not represent the true dynamic changes which occur in the human body. So, ideal way of recording the blood pressure change would be 24-hour ambulatory blood pressure recording. There is a special equipment which is connected to the subject, and the recorder is left with the patient. Patient continues with routine activities, including the night time also. And the BP is recorded automatically every hour in the night also, and at the end of the 24-hour cycle, the graph will be appearing, and that will be the ideal way of knowing the ambulatory blood pressure recording. It is a quite expensive equipment, but some medical companies, some drug companies are offering it free for their patients. So if you are able to contact that person from some of their drug companies, they will do it free of cost to the patient. That service they are offering to the patient. And for us, it's very useful because we can pick up white coat hypertension very easily with this machine. Reverse is also true. When a patient comes to a clinic, some of them may have normal blood pressure, but actually they have high blood pressure afterwards. That's called as masked hypertension. There is no way of looking up this masked hypertension without recording in the house by the patient himself or without use of 24-hour ambulatory BP recording. So we should slowly move away from a static measurement in the clinic to home blood pressure monitoring by the patient, and wherever feasible or possible, go for 24-hour ambulatory BP recording. Next slide. These are the steps to be kept in mind when we record the blood pressure. Patient should be seated on the ground. That should be the correct position for recording the blood pressure. Not lying down, not standing. The first recording should be back supported, patient seated on the chair, feet on the ground, and hand kept on the table, and the BP cuff has to be attached. The cuff should be at the heart level, not the equipment, not the mercury level, not the entire equipment. The cuff should be at the heart level, and hand should be supported. It should not be hanging in the air because the muscles have to be totally relaxed. So, sitting in a chair, feet on the ground, back supported, relaxing for about 5 minutes, hand kept on the table, and cuff at the heart level. That should be the ideal position for recording the blood pressure. And take at least 2 to 3 recordings, take the average of that. In some conditions, you will have to check the standing blood pressure also, especially elderly patients or those who have got possibility of autonomic changes. It's better to check the blood pressure on standing also. Check the BP on standing 1 to 3 minutes after standing, either from supine to standing or sitting to standing, especially on the first visit in elderly patients. Otherwise, you will be treating the blood pressure at the supine level or sitting position, but when the patient gets up, he may get giddiness. Especially this can have a devastating consequence in the night. Elderly patients walk up to the washroom in the night, they wake up, in the slumber, they wake up and then walk. If the BP falls down, and then they'll have problem, they have to go to AYUSH camp afterwards with the fractured femur. And we can prevent fractured femur by properly checking blood pressure and avoiding postural giddiness in elderly patients. Next slide. Similar instruction should be given to the patient for home recording also. Automated devices are very good, well calibrated, and patient should know how to use them. Same instruction, they should be relaxing for some time. They should not check the blood pressure immediately on waking up. They should not check blood pressure immediately after having food. They should go to the washroom and then come back and wait for about 10 minutes. Then sit with the hand supported, tie the cuff at the heart level, and then take 2 or 3 readings, take average of that, record it. And when they do it for multiple recordings, you can have average of that and then give you the average blood pressure, which is a much powerful indicator than what you record as a single recording in the clinic. I agree, all this requires a lot of effort because many of the patients don't like to be they don't like to get all these gadgets or they don't like to record, but there may be a few, some of them who are willing to do that. At least in those patients you can promote so that we are treating appropriate targets. Next slide. And the BP classification has been always a problem. Various kinds of classification have been there based on numbers. Now it has been simplified just to 3 categories. Non-elevated blood pressure, that's the normal blood pressure. Elevated blood pressure, and then hypertension. 120 by 80, less than that would be a non-elevated blood pressure. Up to 140 by 90, that's a border zone, is the elevated blood pressure, but not hypertension. Above 140 by 90 is an established hypertension. So things have become simpler in classification. The first category does not require treatment. Second is a grey area where you would treat if there are other risk factors. And the last category where you will start treatment because it's almost an area where there is going to be organ damage on the long run. Next slide. This is the complicated classification, but I'll just explain that to you. First column refers to the office recording that we conventionally do. Second is the home BP patients, and then last 3 are for ambulatory BP recordings, wherever it's possible. So we will just focus on the first 2. 120 by 70 is a normal blood pressure, non-elevated blood pressure in the office recording. 120 by 70 up to 140 by 90 is elevated blood pressure, and more than 140 by 90 is established blood pressure. But for home recording using automated machines, the cutoffs are different. 120 by 70 and up to 135 by 85 is elevated. But the definition of hypertension is anything above 135 by 85 in the home recording. So the cutoff levels are different using different equipment and setups. In the clinic, 140 by 90 is the blood pressure, established hypertension. But in the home recording, if the average is more than 135 by 85, that patient probably requires to start on medication. Next slide. And the same has been shown here. Non-elevation is 130, less than 120, and ambient recording also shows the same. Elevated blood pressure is where the average of home record 135 by 85. Now, important point is that nobody says you treat all of them. When these guidelines come, often people interpret wrongly, saying that the pharmaceutical industry is lobbying to bring down the threshold. By making it 135 between 120 by 70 to 140 by 90, nobody is suggesting to treat all of them. If there are multiple risk factors or if there are already endocrine damages, treat those patients. All these are by evidence-based analysis. It is not that drug companies just come there and give their numbers. It is not just some experts come and give their numbers. These are all scientific studies. So when the numbers are come down to level of 120 by, so even 124 by 84, we treat if there is associated other risk factor like diabetes, like obesity, like family history of diabetes, heart disease. So it is no more based on numbers, it is an assessment by the clinician as to what would be the risk. That assessment is a very important point that you will have to do in your patients. There are various ways, but you can do it clinically also. So based on your clinical experience and judgment, if you feel that this patient already has other risk factors, treat your 130 by 80. But if the patient has no other risk factors, only one or two ratings are a bit high, up to 140 by 90 can safely wait. So they have they have interpreted as per the context, not going blindly by the numbers. Next slide. So we come back to our patient, 45-year-old male, obese with 140 by 90, what do we do with him? So no doubt that we have to go for appropriate recording and confirm that this is actual hypertension. And then there are other points which will help us to decide regarding treatment. Go by the history. Is it a secondary hypertension? Are there other risk factors? Is it taking any other medications? For example, even simple cough syrups can increase the blood pressure because they contain sympathomimetics. They were using nasal spray. That also oximeter, that is common nasal spray. That is known to be sympathomimetic and push up the blood pressure. Just 2 days ago, I had a patient who suddenly went into palpitations and then heart rate came down. Then we realized it's because of arterial nasal spray. We stopped the nasal spray, palpitation stopped. So these are the simple points that we need to look for. History and also family history. Someone having, if the patient has got strong family hypertension, it is very unlikely that he will be off treatment. He will require treatment. On both sides, we have to be checking both for hypertension and other associated risk factors like diabetes and ischemic heart disease. So focus on the family history. And then also see whether it was a recording error. I've already mentioned how to avoid a recording error, appropriate validated instrument and appropriate method. See whether it was a white coat hypertension. You can easily confirm that by home recording or 24-hour ambulatory beat recording. And then come to the point whether it is established hypertension or are we looking at one-time mild elevation without much of a dangerous consequences. That is where we should look for end organ damage. A clinical assessment for left ventricular hypertrophy. Look for peripheral edema, and if possible, look at the fundus and see whether there are other changes of hypertension. So, any evidence of end organ damage, either by clinical method or laboratory investigations like ECG showing left ventricular hypertrophy, or urine showing proteinuria, or creatinine which is already higher level. All these points tell you that start treatment immediately. The purpose is to prevent organ damage. If the organ is already damaged, then why do you wait? So, patients who have got end organ damage, start therapy immediately. And without end organ damage, probably you can wait for some more time. And when patients start developing hypertension, initially it becomes episodic hypertension. They have BP of 140 by 90 for half an hour, then after comes down to 130 by 80, then 120 by 70. Episodically it goes up and then comes down. So these episodes will continue for some time. That's why when they go to one doctor, they will say there was high blood pressure, another doctor said it was normal. they start doubting the competency of the doctors. Actually, it's a normal phenomenon. It is fluctuating initially. Later it becomes a sustained hypertension. So in the initial phase of fluctuations, if we don't pick up and tell them about lifestyle modifications, we can't prevent that established hypertension. But if we are able to convince the patient regarding the fluctuating nature and highlighting the importance of preventive measures, we can probably postpone the establishment of the hypertension. Next slide. I have already explained some of these features, the proper technique, use of newer machines, automated machines, and the importance of home recording, and importance of overall risk burden. Both in the field of cholesterol, diabetes, and hypertension, we go by risk-based approach, not based on single numbers. So there are various scores, but as I already explained, you are the best judge to decide about that. You have seen your practice. If you feel that the patient has overall risk of cardiovascular and renal complications, that patient needs to be started on treatment very early. And without any of this risk assessment, probably you can postpone your treatment decision. That's where there will be difference of opinion between clinicians, but that's the part of the field is like that. We should not comment about others' judgment because it's purely based on judgment, but judgment is based on scientific factor that higher the risk early treatment, lower the risk the treatment can be delayed. Once you decide to treat the patient, remember that the assessment should be in terms of kidney, heart, and the vessels. The kidneys are assessed based on proteinuria and creatinine level. Both need not be elevated. In a given patient, then only proteinuria, that also is the kidney damage. In another patient, then creatinine may be elevated, protein may be normal. Both are equally bad, and either of them will tell you that this patient. Cardiac evaluation can be by feeling the apex beat or loud second sound, or ECG showing left ventricular hypertrophy. Echocardiography can be evaluated by simple clinical examination. A stiff vessel can be one of the indicators of stiffening of the arteries, and also by specialized methods like the Doppler study. They are not required routine practice. At least do evaluation for the kidney and cardiac evaluation, then decide about the treatment. Next slide. The common lab investigations that are required are sugar value, because you have to definitely rule out diabetes. Presence or absence of diabetes will immediately change your approach for the patient. Hypertension without diabetes is much better than hypertension with diabetes. You will have to look into the cholesterol levels also, fasting lipid profile, or if it's random, you can go for total cholesterol and HDL. That's also sufficient. Check the creatinine and the urine for renal damage. Cardiac evaluation in ECG and echocardiogram. Look for metabolic syndrome. Metabolic syndrome is a loosely aggregated syndrome of, say, overweight, hypertension, diabetes, and dyslipidemia. And anyone with abdominal adiposity is a strong risk factor for a metabolic syndrome. So those with metabolic syndromes, you can pick them up easily with the abdominal fat. If they have got significant abdominal fat, they will have metabolic syndrome. And such patients do require aggressive approach. If there is diabetes and sugar, I call it double trouble. Individually, they are dangerous, but when they are together, it is multiplied, not by 2 or factor of 3 or 4. You will also see in clinical practice that whenever you see this disease in combination, hypertension and diabetes together is a powerful risk factor for cardiovascular complications. So don't ignore them. These double troubles can have to be addressed very aggressively. And then the treatment is not necessarily medication. Very aggressive lifestyle modification required. And if the endocrine damages, you will have to go beyond lifestyle modification and start pharmacological approach also. Next slide. And what are the lifestyle modifications? Our 45-year-old patient with abdominal obesity, 140/90, luckily he doesn't have diabetes. What do you do with him? First, you would have checked his creatinine, urine examination, left ventricular hypertrophy, nothing is there. And if possible, we would have gone checked his ambient BP recording, maybe it is not showing average of say 135 by 85, just in the threshold. Probably this is the patient where a good lifestyle modification is appropriate. Organ damage are not yet setting, just at the threshold of cutoff level, go for aggressive lifestyle modification, which will include periodic regular exercises, diet restrictions, and of course relaxations. Exercises, they don't have to go for jogging, they don't have to go for workouts. Just about 140 to 150 minutes of walking every week is sufficient. And add a few more resistive isometric exercise also. But main thing is to have sustained regular physical activity, about 150 minutes of brisk walking per day. That's good enough. And then of course salt restriction, avoiding fried food, and having every day good amount of fruits, vegetables and nuts, and good potassium in the diet. That will go a long way in preventing an establishment of high blood pressure, and that will can reduce the BP load, and with that cardiovascular risk reduction. That is the ultimate goal. Next slide. There are many medications for blood pressure. Priorities for the blood pressure reduction. Bring it down at any cost. Which tablet? That actually doesn't matter. There are many medications, and for blood, as far as blood pressure is concerned, bringing it down is very important. Some of the good medications are expensive, the patient can't afford. Even old medications are sufficient as long as BP can be brought down. And there are some compelling indications for certain class of medication. Basically, we have got 4 classes: A, B, C, D. A stands for angiotensin ACE inhibitors or receptor blockers like enalapril, lisinopril, or telmisartan, losartan. B stands for beta blockers. C stands for calcium blockers, and D stands for diuretics. We have got other medication like hypertension or reserpine or chloride. It doesn't really matter as long as BP is brought down. If the patient can't afford newer medication, if they can't afford expensive medication, at least do the older medications. Professor Mani, who is a famous nephrologist from Chennai, has shown in an elegant study in a field level, in a community level, that as long as the BP is brought down, even if it is a older medication, it does not matter, it gives protection. So the priorities for reduction of the blood pressure, in addition there will be some compelling indications. For example, if there is prostatic hypertrophy, go for an alpha blocker. If there is asthma, avoid a beta blocker. If there is ischemic heart disease, beta blocker is indicated. If there is proteinuria, prefer ACE inhibitors or angiotensin receptor blockers. So in diabetic patient, there is high blood pressure. If there is no proteinuria, you can give calcium channel blockers. But if there is proteinuria, you should prefer telmisartan or enalapril. So that's how we go by the compelling indications to decide what is to be given. There will be some contraindications for certain medications. For example, if there is glaucoma, you should avoid certain medications. If there is heart failure, you must avoid alpha blockers. If there is a rising creatinine, you must avoid ACE inhibitors and ARBs. So there are certain contraindications for certain medications. Beta blocker was a very much preferred drugs about 20 years ago. Now it will go to the back seat. Now the preference is for A, C, D, not the B. Because the studies have shown that beta blockers, although they reduce the blood pressure, they don't substantially reduce the cardiovascular complication that is required, or they do not prevent so much of stroke. But if the patient already has ischemic heart disease or mild heart failure, then beta blocker becomes a preferred treatment. So generally we give A, C, D and add beta blocker if required later on. Next slide. Calcium channel blocker is a very preferred drug because it's quite potent. So we start with a single drug if the BP is marginally elevated. If there are no other risk factors, there is no target organ damage. But if there are target organ damages, we have to go for combination medications, which can consist of calcium channel blockers like nifedipine or amlodipine or cilnidipine, with either a diuretic, a long-acting thiazide diuretic, not furosemide. Preferred diuretic is thiazide like diuretic. And if the BP is still not under control, you can go for triple combination. And if the BP is still not controlled, you can add beta blockers. Then you can think about adding chloride and other medication. But this is only suggestion. Please remember that what is important is to bring down the blood pressure. we may have modified in our own practice based on what the patient can afford and what's available. Next slide. And when the BP is on the lower side, check the standing blood pressure, avoid the antihypertensives and reduce the dose. If the BP is 120 and up to 130, it is a safe level, but treat it if there is risk factors. If the blood pressure is more than 140, cardiac damage is already there. Various levels of blood pressure will help you to decide the treatment. Next slide. So this patient has been put on medications. Our 45-year-old patient was a busy executive. After some time, he comes back with the edema of the feet. He has been on a calcium vacuum, obviously. Then what do? Either tell him that this is an innocuous side effect. If he is not really worried about that, he can continue with that. But invariably, patients don't like it. They always relate edema with a kidney problem and they want to change the tablet. If they really want to change, you can change it to either telmisartan or a combination of telmisartan and hydrochlorothiazide. This is a very preferred combination, very potent combination. But the problem is, many of them develop hyponatremia with this combination. So our patient, after starting this tablet, after about a month or two, he comes back with severe fatigue, drowsy, ataxia and giddiness. You check his sodium, especially when a patient is on a combination of telmisartan and thiazide. Check the sodium. If they complain of non-specific tiredness and fatigue, sodium might be low. And if that's the case, take out hydrochlorothiazide. Continue with the telmisartan and a combination of calcium channel blocker. Next slide. When they have multiple diseases, cholesterol, sugar, and blood pressure, which is more important? Which is a major villain in this combination? Generally, we tend to think about diabetes as a major complication, bigger villain. But studies have shown that treating cholesterol gives a much stronger benefit than treating diabetes. Treating hypertension gives a much better benefit than treating sugar. So the focus should be on an appropriate lipid control, blood pressure control, and then sugar control. So our patient who has been already put on antihypertensives after say 2-3 years now comes back with a fasting sugar of 118. Now when we see only 118, our tendency is to say you're not a diabetic, diet control, and he goes every function has bias and everything as before. And then whenever sugar is slightly, he blame it on the previous day mangoes or functions. And then after 4 months, he comes back with HbA1c of 9. Just 4 months ago, you told me he's not diabetic, and then he comes back in 4 months with the A1C of 9. He's going to the previous doctor or the previous lab. Actually, the recording was not wrong. We went by his fasting sugar, forgetting to check his PP sugar. In India, based on our diet, PP sugar is a much important target to detect diabetes. Many of them will have PP sugar of 210 or 220, fasting sugar of 110. That may be because of our food habits, which are very rich in carbohydrate. So this patient, subsequently when the A1C was high, was found to have a PP sugar of quite high level. Then what do you do? His sugar is, do you go for lifestyle modification? Or do you give insulin? Or do you go for OHA? Just because sugar is 9, don't think that he requires insulin. Earlier, when the A1C was very high, we were jumping to start insulin and scaring the patient. I have some of my close relatives who, with aggressive lifestyle modification, brought down their A1C from 9 to 5.5. It is still possible. So, if there are no endocrine damages, there is no proteinuria, if there is no high blood pressure, if your patient can go for a strict diet and lifestyle modification, give them the chance. And this cousin of mine is more than about 2 years, he is not on medication. His sugar was A1C was really 9, now it is better than mine, it is 5.7 now. Modification and can be put on regular monitoring, give them a chance to avoid medication if possible. Next slide. Once you decide to put him on treatment, I am talking about modern medicine or allopathic medicine. All systems can be tried. We go for OHAs. Which OHA? There are a lot of newer OHAs. Earlier we used to have glycine, sulfonylurea, metformin. Now we have got GLP-1s, neurogam variety, and SGLT2 inhibitors like dapagliflozin. There are many types of OHS available. Based on their other risk profile, we decide that. For example, if the patient got a proteinuria, type 2 diabetes, we have to include dapagliflozin because that reduces proteinuria also. Sulfonylurea like glycemic, glycemic are very strong medications, but they do not provide any cardiovascular benefit. So in the field of diabetes, we don't look at numbers alone. We go for drugs which have proven cardiovascular benefit. And unfortunately, all our popular diabetic medications like glycemic and glycemic do not have any cardiovascular benefit. They bring down the sugar, but they don't prevent cardiac complications. Whereas our good old metformin is cardioprotective, and a newer medication like dapagliflozin is cardioprotective, renoprotective. So we have to select the medications not based on the action of the sugar alone. We have to go for organ protection also. Next slide. This is a very busy slide with a recent guideline. I put it to highlight the fact that now the importance is given for SGLT2 inhibitors mainly because of the proven safety and efficacy, but in a given context, metformin is good enough. So, in our context, metformin should be the first drug of choice. Then go for sulfonylurea or SGLT2 inhibitors like dapagliflozin, canagliflozin. We should remember the side effects. Many of them will produce urinary tract infections and vellum bursitis when we give dapagliflozin. We should be aware of the side effects. Next slide. Now, he has been quite happy with your treatment. So he is getting his elderly dad, who is 76-year-old. The next visit, he came back with his dad for treatment with you because this patient, his elderly dad, 76-year-old, has got hypertension, diabetes, and he complains of fatigue and giddiness. You check the blood pressure standing, lying, sitting blood pressure was 150 by 94, on standing, BP dropped down to about 110 by 70. This old man is suffering from postural giddiness due to antihypertensive medications, coupled with diabetes also. So the BP targets are different. For a patient who is young, where you want to prevent every other possible organ damage, you go for aggressive BP targets. But in elderly patients, your target should be relaxed because otherwise they will go for postural giddiness. Patients who have got severe heart failure also should be having relaxed targets. And we should personalize our target for various clinical conditions. Similarly, is the sugar target also. For this old man, 76-year-old, he could be having hypoglycemia also, and that could also be a reason for his giddiness. The target of HbA1c of close to 6.5 is only for younger patients where they have got a long way to go. But patients with established organ damages, for example, already had myocardial infarction, or CKD, or elderly patients, we should relax the target to 7 to 7.5 A1C. We don't have to go for 6.5. Next slide. After some time, his dad got the casualty, unconscious. And he had hypoglycemia, and it was attributed to the poor dinner which he took the previous night. Are you worried about this? Improper food intake the previous night. A long-standing hypertension and diabetic, always remember possibility of a worsening of the kidney function as a cause of hypoglycemia. If a patient's sugar unusually comes down, check his creatinine. As the creatinine goes up, sugar comes down. So the new onset of hypoglycemia could be heralding or indicating an underlying creatinine. Don't simply attribute it to the poor intake the previous night. Check for creatinine and maybe creatinine is on the higher side. Next slide. And with this success of the treatment for his dad, he is very happy. He brings his younger nephew for the next visit. 20-year-old young boy coming with recently diagnosed diabetes. Till recently, all young diabetes we were labeling as type 1. But now we know that it could be type 1, type 2, or pancreatic diabetes also. So every young diabetic is not a type 1 diabetic. Every young diabetic is not insulin dependent diabetes. If you don't investigate this patient, they may be unnecessarily put on lifelong insulin. Think of possibility of a early onset type 2, or it could also be a pancreatic diabetes. It could be having pancreatic calcification. So some more investigation is required in these patients to rule out these conditions. Next slide. And another important point regarding interventions. We got lifestyle modifications. For example, our patient now 55. We started at 45. At 55, he has a lot of stresses in life. That's the age when there is a lot of stresses both on family side, professional side. His TMT was done. It's positive. And now he says he wants to start lifestyle modification. And he wants to go to naturopathy for lifestyle modification. What would be your advice? All these interventions are stage specific. Lifestyle modification gives the best result in early stage, not once organ damage has occurred. Typically, they get the urge to be very aggressive with the lifestyle modification. That is not the time to be aggressive with the lifestyle modification. That was when there was initial diagnosis. So the interventions are stage specific. Lifestyle modifications are the best in the initial stages. Metformin and other medications are the best in the intermediate stage. Once there is organ damages, creatinine gone up, then it's the stage for insulin. You can't be talking about metformin once kidney cell failed. So the way you will treat will depend upon the stage of the disease, not based on the medication that is available with you, not based on whether the drug is new or old, not based on the fact whether it's expensive or not. It is a stage that matters. So evaluate the patient for the appropriate stage of the disease. Next slide. And we go beyond numbers. For hypertension, go beyond the blood pressure. Some medications have got more organ protection. For example, ACE inhibitors and AR based are very much nephroprotective. Calcium blockers are very good for isolated systolic hypertension because among all the medications, calcium blocker is the most potent one to bring down the blood pressure. So we should go beyond the numbers and see how they can benefit for the patient. Even diabetes, as I already mentioned, it is not just the fact whether the sugar is a problem, whether it is an organ protection or not. It goes not only for allopathic medicines, for all AYUSH medicines also. It is not just the reduction of blood pressure. See whether there is any overall improvement in the risk factors and whether we are protecting, whether we are preventing cardiovascular events. Overall risk reduction and reduction in cardiovascular mortality is important. Ultimately, it is not our goal to bring down the blood pressure or bring down the blood sugar. Our goal is to prevent deaths and prevent mortality. Next slide. So, I have taken you through the combination of risk factors that hypertension and diabetes properly, appropriate measurement techniques, the newer techniques that are available, maybe a bit fanciful right now, but over the period of next 1 decade, I'm sure it will become a routine. And overall approach for these patients, how to evaluate them clinically, and with the example of one patient and how it evolved, I've explained to you the importance of appropriate evaluation and the decision to treat, when to treat, and when to intervene and how to intervene, and a few points regarding the drugs available for these two diseases. I thank once again all of you for your patient hearing, and especially Dr. Pradeep and Dr. Sushma for giving me this opportunity. Mainly because every time I address on AFI, I see so much of enthusiasm and willingness to learn new things, which I don't see with modern medicine. I used to come and say I am in meetings. The hall will be full only at the end of the meeting. And I am happy to see that hall is full in the beginning of the meeting also. And I compliment all of you for this and wish you all. Thank you.
ಸತ್ಯ ಸ್ಪಷ್ಟ ನೇರ ಸುದ್ದಿಯೊಂದಿಗೆ UPlus TV. ಇದು ಹೊಸತನದ ಸಂಕಲನ.
ಪ್ರೀತಿಯ ಸಂಕೇತ ಅಳಿಯದ ಸಂಬಂಧ ನಗುವಿನ ಸೌಂದರ್ಯ ಇದು ಸ್ನೇಹದ ಬಾಂಧವ್ಯ ಒಲವಿನ ಪ್ರತಿಧ್ವನಿ ತಂದಿದೆ ಸಂತಸ ಚಿನ್ನದ ಪ್ರತಿಹನಿ ತಂದಿದೆ ಸಂಭ್ರಮ ಮುಳಿಯ ಜ್ವಲ್ಸ್ ಕಣ ಕಣದಲು ಆನಂದ ಮುಳಿಯ ಜ್ವಲ್ಸ್ ಕಣ ಕಣದಲು ಸೌಂದರ್ಯ ಮುಳಿಯ ಜ್ವಲ್ಸ್ ಕಣ ಕಣದಲು ಆನಂದ ಮುಳಿಯ ಜ್ವಲ್ಸ್ ಕಣ ಕಣದಲು ಸೌಂದರ್ಯ
creating happiness.